Good evening. I'm going to give you a fairly good education in the next 15 minutes about shoulder replacement. And we're going to talk about why we do it, how we do it, the different types of shoulder replacements that we do use. And following up what Dr. Ennis just said, in my practice, I think shoulder replacement surgery is probably the most rewarding operation because patients are extremely disabled with pain. They can't use their arm, they can't eat, they can't dress, they can't bathe, they can't sleep, and they're really quite miserable. And within a week or two after the surgery, even at their first post-op visit, which was 7 to 10 days, they're amazingly better and really quite thrilled. So it's a good operation, it's very reliable, and I'm going to tell you a little bit about it. Now there are two types of shoulder replacement, and there's what we call a primary shoulder replacement and a reverse shoulder replacement. And I'm going to talk about the differences, why we do them, and what can go wrong, though fortunately things don't go wrong very often. The prosthesis that you see on your right on the top is a primary shoulder replacement. It has a stem, it has a metal ball, and it has a plastic socket. And it replicates sort of the normal anatomy of the joint. And the one on the bottom also has a ball and a socket, but they've been switched, and that's known as a reverse replacement. In order to understand the operation, you need to know a little bit about the anatomy of the joint. And the top of the arm is the humerus, and the top of the arm is called the humeral head, and that is normally covered with cartilage, and it abuts up against the socket, which is known as the glenoid. And similarly to the hip and the knee, what happens in arthritis is we lose cartilage. And when we lose cartilage, it becomes painful, just like in a hip or a knee. The shoulder joint is probably the most complicated joint in the body, and it is surrounded by many muscles. There's a top layer, a superficial layer of muscles, which is primarily the deltoid muscle. And in the front of the body is the pectoralis muscle. And when we do the surgery, we actually go in between those two muscles. There's a deep layer, which is known as the rotator cuff. And the rotator cuff is a group of 4 muscles, one big one in the front, and actually 3 in the back that help you raise your arm. And the rotator cuff is important when we talk about shoulder replacement because you need the rotator cuff to lift your arm. However, with the advent of a reverse shoulder replacement, you can lift your arm again now without a rotator cuff. And I'll show you why in a few minutes. How do we evaluate shoulder pain? Well, we'll often do in the office a simple shoulder x-ray. And you can see on the diagrams that there's normally a space between the humeral head and the glenoid, and that space is maintained by cartilage. The x-ray on the right shows a much more narrowed space, and there's a little spur at the bottom of the ball, and that's a typical x-ray of shoulder arthritis. So the cartilage has been lost, and the two bones start to wear up against each other, which creates pain, and the reaction to the increased stress on the bone is spur formation. So that's a typical x-ray of fairly severe osteoarthritis. Arthritis in the shoulder is similar to arthritis in the other joints. It hurts when you go to move it, it hurts when you lie down, and eventually it continues to hurt when you just do nothing. The exam, swelling we sometimes see, there's catching, snapping, it hurts when you move it, and if you look at the two photographs, the top one is a picture of a humeral head with normal cartilage, which is white and glistening and smooth, and the bottom one is an arthritic humeral head, which is now abnormally shaped. It's pitted, it has very little cartilage left, and the nerve endings in the bone from this create pain. Treatment is similar to what you've heard. We use physical therapy sometimes, we use medications, we will use cortisone injections, and we try to get people by for as long as we can without moving into surgical options. And the conservative management can be quite helpful for a number of years. It's not a weight-bearing joint, So people tolerate shoulder arthritis, I think, a little bit better than they tolerate hip or knee arthritis, where it's weight bearing. Eventually, though, sometimes those things aren't successful, and we start talking about surgical options. And there's two categories. One is arthroscopy, where we can go into the joint with a little camera, and we can clean up the joint, which is called a debridement. We can smooth the cartilage, which is called chondroplasty. We can remove any loose pieces, and if the joint is stiff, we can release some of the capsule to help it move better. An arthroscopic intervention for arthritis can be quite helpful as long as the arthritis is in the mild to moderate category. It doesn't work very well at all for severe arthritis, and I don't recommend it. There are still some people doing it, but it generally doesn't work. For more advanced arthritis, we start talking about replacement of the joint, and you can replace part of the joint, just the ball, that's called a hemiarthroplasty. Or you can replace both sides of the joint, which is a ball and a socket. And there are two types, as I mentioned, the standard, or what we call primary, or the reverse. The hemiarthroplasty, just replacing the ball alone, we can do in a younger patient if the socket is not too involved, or if the socket is severely involved and there's not enough bone to support a replacement. There are some doctors who aren't really comfortable with total shoulder replacements. They do hemiarthroplasty. And we used to use this procedure when people had a badly torn rotator cuff before we had the reverse. The total shoulder replacement was really promoted by a guy named Charlie Neer, who was a Columbia Presbyterian. I was fortunate enough to do my shoulder fellowship with him just a couple years ago. And he really was a world-known shoulder surgeon. And thanks to him, a lot of the shoulder procedures that we do today are highly successful, including shoulder replacement. But his concept was to recreate normal anatomy as much as possible, to leave as much bone as possible, to make it unconstrained or no mechanical stops, and to treat the muscles around the joint, because I mentioned it's a very complicated joint with a lot of muscles, and they're equally important to the success of the surgery. There are different types of arthritis, and there may be a quiz at the end, but by far and away the most common is osteoarthritis, which Dr. Cavanaugh mentioned is known as wear and tear, and that's the most common one that we see. But there are many other types of arthritis, but they all result in a loss of cartilage, which is painful. So this shows you how to do a shoulder replacement in 7 easy steps. I don't recommend trying this at home, but if you follow the diagrams, the arthritic head is actually removed. We create a little channel in the bone. We create a channel in the socket. We then put a metal prosthesis into the bone. We put a plastic socket on top of the arthritic socket after it's been shaped. And then we put the appropriate size metal ball. And that creates 2 new surfaces that can now move and not cause pain. So it's really a resurfacing. And that's a standard shoulder replacement. And it recreates the normal anatomy. And here are the x-rays of what it looks like. You can see an x-ray showing arthritis with very little space. And then an x-ray showing a metal ball and a metal stem in the bone. And the plastic socket you really can't see very well, but there's a little metal marker in it. But you see there's a nice space now between the metal ball and the bone. So this is simple animation of what happens. So you can see actually when you raise your arm, you're getting motion from the ball and socket and also motion from your shoulder blade moving on your back. So now the rotator cuff. This becomes important when we talk about reverse shoulder replacement. So the rotator cuff, as I mentioned, is 4 muscles and tendons that attach to your upper arm. The middle diagram is actually an MRI with the arrow pointing to a tear. So the white is actually fluid that shouldn't be there, and the black tendon is no longer attached to the bone. And on the far right, there's an arthroscopic picture of what a small rotator cuff tear looks like. That type of tear is easily fixed with arthroscopic surgery. But if all of those tendons, or even 3 of the 4 are torn, sometimes they're not repairable. And in that situation, we have what's known as a force imbalance. What happens then, the deltoid, which is trying to pull your arm up, actually pulls the whole humeral head high up against the scapula, and people can't lift the arm, and it hurts. And that becomes a non-functional or unstable joint. And the problem then is, how do we solve this? So years ago, we would do hemiarthroplasty, and Dr. Neer called this a limited goals procedure because he knew from the start that it wasn't going to give as good a result if you could do a total shoulder replacement. So the woman on the far right had a hemiarthroplasty, and she could only raise her arm part of the way up, but her pain was improved, but she didn't regain much in the way of function. If you try and put a total shoulder replacement in a patient without a rotator cuff, the socket gets loose because the metal ball is pushing up against the top of the socket, and it causes it to loosen. Bad idea. So in 2004, the FDA approved the use in this country of the reverse prosthesis. And this was designed to allow the deltoid alone to lift the arm, and it's designed not to loosen the glenoid as the primary shoulder replacement would. So this gets a little technical, which is probably not really necessary, but the diagram shows you that there's a metal ball that's been placed where the socket was, and we create a socket in the upper arm. And this allows people now to raise their arm without a rotator cuff. So again, here are the two different prostheses. The reverse prosthesis you can see on the left, and the standard prosthesis on the right. So similarly, there's the reverse prosthesis. And again, you can see people should be able to lift their arm, but the configuration now has been changed. This is a gentleman who came to see me in 2006. He was the first patient that I did a reverse replacement on. He was actually the first in the state of Connecticut to have a reverse replacement. And he had had multiple attempts at fixing his rotator cuff. You can see the different incisions on the top of his shoulder. And he was a retired steam fitter, and he'd done a lot of work with that arm over many years. But he was very unhappy. He couldn't lift his arm, and it hurt. And that was as far as he could move it, both sideways and forward. And his x-ray looked like this. So you can see this was February of 2006. And the little metal things in the ball are anchors that previous surgeons had used to try and fix the rotator cuff. But that had failed, and he couldn't lift his arm. So I did the reverse replacement, and this is a 3-month post-op x-ray. And if you look at the x-ray, you see that the metal ball now is actually screwed and anchored into the scapula, and in the arm, there's now a socket. And he's lifting his arm without a rotator cuff, just with his deltoid. Another patient, reverse shoulder replacement, quite happy. So the reverse is a great operation. It's probably been the biggest change or greatest change in the world of shoulder surgery in the last 10 years. It's being used, I think, more frequently now as people are getting more familiar with it. We use it for certain types of fractures as well, particularly in elderly patients who have fractures, sometimes that aren't likely to heal. We'll use a reverse replacement. The statistics in terms of complication rate, when we first started using them, were that reverse had a much higher complication rate. But, and there's a long list. Some of these you may want to know about or not, but at the bottom of this slide, you can see that our complication rate is extremely low. And I think it's for multiple reasons. One, we've been very careful about who we do this operation on. And two, it's done by myself and another one or two of my partners who really have a lot of experience with the procedure. And it makes a very big difference. But it's been a great operation. Here's a gentleman who, 2001, had a hemiarthroplasty. 2008, he had a reverse. And obviously, he's doing much better with the reverse. So that, in a nutshell, is where we stay at the state of the art on shoulder replacement surgery. And I'll be happy to answer questions once we get to the Q&A. Thank you.